The first thing we do is we need to do a risk score assessment. We need to assess the risk of stroke, and we need to assess the risk of bleeding. The risk of stroke can be assessed using the CHAD score and the CHAD's VAS score for more precise identification of risk in patients whose CHAD score is less than 2. Once you make the decision to use an oral anticoagulant, then you've got to make the decision as to whether to go with warfarin or to go with one of the new agents. And the new agents are certainly much simpler to administer. There are fewer drug-drug interactions. You can eliminate the routine monitoring, and they have potential efficacy and safety advantages over warfarin. So if the patient can afford it, I would go with one of the new agents. And then the choice is which of the new agents. Right now the decision is easy because dabigatran is the only new oral anticoagulant that's licensed for use for this indication. I think it'll become a little more challenging when we have choices, when rivaroxaban and apixaban are also on the market. And then you might make your decision based on whether the patient can manage a twice-daily regimen versus a once-daily regimen. But the biggest decision is already made when you decide to put the patient on an oral anticoagulant, and then it becomes fine-tuning as to whether they go on one of the new agents or warfarin, and if they go on the new agent, which new agent. And all of the new agents are looking very promising in the atrial fibrillation setting. We see with apixaban a reduction in stroke and systemic embolism and a reduction in major bleeding, so that's a big advance. We see with dabigatran, we could pick a dose. The 110 dose isn't available in the United States, but you could pick a dose based on the risk factor profile. And for rivaroxaban, the nice thing about rivaroxaban is the once-daily dosing and the fact that this drug has been really tested in patients for secondary prevention, the very, very high risk, very ill patients with multiple comorbidities on multiple medications. So that's also a very reasonable choice in your high-risk patient. So I think the decision will be made more on patients' insurance for coverage of drugs, their willingness to take twice daily versus once daily, and then the choice becomes one of those issues.